Hi, my name is Dr. Derek Lee. It's my pleasure to welcome Dr. James Sanders. Dr. Sanders is a Frank C. Wilson Distinguished Professor of Orthopedic Surgery, Chair of the Department of Orthopedics at the University of North Carolina at Chapel Hill. Welcome, Dr. Sanders.
Thank you, Derek. It's nice to meet you.
Who better to talk to with respect to the Sanders Skeletal Maturity Staging System than Dr. Sanders? I was wondering, if we go back to the beginning, what was the impetus that you developing a new system?
Well, so let me go back a little bit even further than that. I became very interested in how growth and the spine interacted from Jean Dubussé. I met him many years ago, back in 1986, when I was an intern, and he came down to San Antonio. I got to go out with him, and he started talking about this thing called the crankshaft phenomenon, which I was brand new. I had worked with Vern Tolo as a medical student at Hopkins, and then going to San Antonio and hearing from Dubussé about this new thing that he was talking about. I'd heard about Dubussé because there was these new controlled Dubussé rods, and he was just a wonderfully warm human being, a very good thinker. And I started thinking that there's got to be a way to figure out when kids are going to have crankshaft and when they're not, and when they're so young that they're going to have it, and when they're mature enough that they're not going to. So I sort of kept that idea in my mind while I did my residency. And then I went to Texas Scottish Rite Hospital, and I convinced Tony Herring to do a research project on that when I was a fellow. And we pulled up all the scoliosis patients that they had treated who had earlier onset scoliosis. And what we found was that looking at the triradiate cartilages gave us a really good idea of when it was going to happen and when it was not. And that was sort of a surrogate for some stuff that Alain Demiglio in France had done. He had been looking at when the triradiate cartilage closes, when the peak height velocity was occurring, and it made sense that this was related somehow to the peak height velocity. Then David Little was at the Texas Scottish Rite Hospital, and he and Kit Song did some work directly measuring the peak height velocity and finding that they could make some predictions based about bracing and when bracing was going to fail in both boys and girls. And so I took that and thought, well, instead of looking at the triradiates, why don't I look directly at the triradiate cartilage? Look at the peak height velocity. So I began looking at that, and sure enough, the peak height velocity, when you measured it, was a far better predictor than just even looking at the triradiate cartilage. So I subsequently then wrote a grant to the Scoliosis Research Society, and this was back in the early 1990s, mid-1990s, to begin looking at various maturity measurements in girls and starting to figure out, as kids were going through their growth, which of these maturity measures would give us the best understanding for what was going on. So I teamed up with a pediatric endocrinologist at the University of Pittsburgh. I was at the Shriners Hospital in Erie at that point. And we began looking at the different things that were out there. So there were several hormone levels. We were looking at direct measurements of peak height velocity. We got bone ages, which I'd been told were not very good for all of this. And we started looking at all of the things. And lo and behold, the best predictor for what was going on as we went through this ended up being the skeletal maturity of the hand. And there was a staging system which was developed by Tanner. People may have heard of the Tanner classification for looking at maturity, which looks at the development of the breasts and the testes and pubic hair and things over time. But he had also developed a skeletal maturity measurement system of the hand. And lo and behold, that seemed to predict very well, particularly how the digits appeared, the fingers appeared on the X-ray. And we could correlate it very well with what was going on. But it's a complex system, and to sit and do it was a real challenge. So we published several papers looking at the correlation between the peak height velocity, how the curves behaved, and maturity. And once we were kind of done with that, it made sense. We needed to make something simple enough for people to use in clinic. So what we did, and it became known as the Sanders because I came up with it, but was really just looking at the digits and finding out what it was that was in the Tanner Whitehouse method that correlated really well with what was happening with the child's growth and therefore what was happening with the curves. Because we found all the curves took off at the same skeletal maturity stage, regardless of what the curve type was. So it was very interesting and very tightly correlated. So that's how how it came into being. We've had some minor modifications to it. We've added we've added a 3B and now there's a 7B for some different parts of it. But it's been a very reproducible, really relatively easy to use scale that an orthopedist can use in the middle of clinic to help them make decisions.
Right, and speed and convenience is a huge issue, right?
Makes a big difference, yes. And I'm sure, we're going to get AI techniques that are going to let you look at a bone age and get, much more accurate than that. But if you're looking at it in the middle of a clinic, you can put it up, you know what it needs, you know where the child is within their growth spurt, and it can give you some pretty good predictions on what's going to happen. And I'm sure you're familiar with the BRACE study that looked at and found, that bracing was efficacious. They also collected hand x-rays on a large number of the children that were in that. And so Laurie Dolan has gone back, and the University of Iowa has actually made a scoliosis prediction site on what a curve is likely to do. And they have it both for the wrist sign and they have it for our hand stages as well. So you can look at it on either of those.
Absolutely. You've already posted that on my site. And I talked to Dr. Stuart Weinstein about it. He's terrific, actually. So
he is.
I talked to him about the natural history of scoliosis over 50 years with his school study as well. All right. So before we get sidetracked too far, I was wondering if I could pull up some X-rays and you could take us quickly through the Sanders stages.
Sure.
What to look for and what makes each stage specifically that level.
All right. So this is the early stage. This is a child who has not yet begun their growth spurt. So a little bit like RISR 0, it encompasses a very long period of time. Most girls are still in this stage until somewhere close to 9 years of age. Most boys are still in it until 10 or 11 years of age, about 2-year difference between boys and girls in terms of when they undergo their growth spurt. So there are several different parts of the bone. This part is called the diaphysis right here. This is the thumb. And each of the bones also has something called an epiphysis, which will eventually, when someone is fully grown, will unite with that and make a single solid bone. The thumb epiphysis is right here for the base of it. For the next joint, it is right here. On the fingers, it's a little different. So this is called the metacarpal, and on that metacarpal, this is the diaphysis, and this is the epiphysis. As you go further toward the end, it's called the proximal phalanx, this is the diaphysis, and this is the epiphysis. It's called those things because they are right alongside this clear area on the X-ray, which is the growth plate, which is the physis. So it's the diaphysis and the epiphysis, and the metaphysis is right next to it. But it's this that you are looking at compared to this. And in a child who has not yet gone through their growth spurt, what you see is that not all of these are as wide as the diaphysis or the metaphysis next to it, particularly here on the 5th digit. It's the last one to get as wide as the others. This is still at a stage 1 because this epiphysis is not as wide as this metaphysis right here. So that's a stage 1. On stage 2, which I assume will be the next ones here, let me see if I can, right here. So this one, you can see they are all as wide. So every one of them, as you go through this, is as wide as the metaphysis next to it. That is early in the growth spurt. Once a child is started with this, their growth spurt has begun. There's a few other hints that you can use to figure out someone is in that stage. There is a little tiny bone right here off the side of the thumb that's called the sesamoid. Usually during this stage, the thumb sesamoid starts to form, but it's not very big. When you get to the next stage, it's pretty big and it's pretty well formed. But during this stage, it's not very well formed. And then on the next stage, which is stage 3, which is when kids are really at their maximum growth, what you see, if you look very closely, and I'm not sure if I can zoom in or not more, is that these edges, and I'll show it on the drawing here, begin to curve around the edge. And here on the thumb, it's pretty easy to see. And it's called capping when that happens. And once the majority of these are capping, they're in stage 3. We've made a stage 3B because we found when we were looking at limb lengths that it helped to have that. And that's when this distal radius here is also beginning to cap, which it is on this. You can see it's beginning to curve a little bit around the radius on this portion. So that's a stage 3. Stage 4, they're beginning to fuse. And the bones begin to fuse at the most distal portion. So down here, the most distal means it's toward the tips. So it begins to fuse in these areas down at the very tips. Once that's happening, growth is beginning to slow down. All of these are still capped. You start to see them close. And then very close in timing to that, all of the ones in this distal or the most further away from the body portion have fused. And so those two tend to occur. The stages 4 and 5 tend to occur very closely together, and growth is really slowed down at that point. And then in stage 6, some of the others begin to fuse. So these other areas begin to disappear, but haven't fully disappeared altogether. In stage 7, everything is closed except for the wrist at the distal radius and the distal ulna. There's now a stage 7B where the ulna has closed, but the radius has not. And many people are now saying that you should continue bracing until you get to that 7B because progression is less after that. And then stage 8 is when everything is closed. And that's when this turns into essentially an adult looking hand. You see that there are no more growth plates. They're all gone and they're fully fused. That's it. That's the classification.
Excellent. Now, if you advance a couple more slides for me,
Sure.
so it's a little bit of a chart. I was wondering if you could talk about the significance of this, this breakdown.
Sure. So this is only for thoracic curves. And so we had to create a modified classification for this. And so we took the Linke classification, which was meant for surgery and requires bending films. And so we had to make some assumptions with it, but it's been used a lot since then as a modified Linke classification. We took those that had a major thoracic component, where the thoracic was either the entire curve or it was larger than the lumbar curve or more structural than the lumbar curve. And among the girls that we followed in this study. And we did a regression to figure out, and it's called a logistic regression, to figure out what was the probability of a curve of a certain size at a certain skeletal maturity going on to a surgical range, which we assumed was greater than 50 degrees. That was the assumption that we used with it. And so what you see is that if you have and can you still see my mouse moving?
Yes, can.
Okay. So if you have a 25-degree curve, and you have a child who's at skeletal stage 1, then you have about a 99, really somewhere between 68 and 100% chance of that curve going on to a surgical range, assuming it's not treated. Stage 2 would be 100% very similar with this. But if you get to stage 3, which is still risk or 0, you end up really dropping down. And stage 4 and stage 5 are often risk or 0. And so you see that you go from 100% down to almost 0% while still risk or 0. And that's where the risk sign really broke down, is because it did not reflect what is going on during this period of time. And then, so we did that, and you can look at all the different curves. This is the curve size, the maturity is up at the top, and you can sort of see what those are. This has been reproduced now a couple of times by other people at other sites. So it's been reproduced. DuPont put together a study looking at this. CHOP, Children's Hospital of Philadelphia, has also done a study looking at this. So it's held up over time. So in general, while the numbers get more granular as you go to the larger studies that they have done, ours was an initial, a pretty small study. This is a pretty good indication of how curves likely to behave over time.
Excellent. Actually, I talked to Dr. Sukin Shah, who basically was one of the NEMORs who basically expanded your study to think about almost 200 cases. And he said, yep, Dr. Sanders is right on. Now,
Yeah, so it's withstood the test of time, which is good.
Yeah, absolutely. Now, I'd like to also talk to you about early onset scoliosis. with early onset scoliosis, it starts so young. And what was interesting to me is that with casting from, especially if you get a child at about 1 year old, you have a pretty good success rate of actually stopping and curing scoliosis, which I didn't know before, which is amazing. What happens if casting fails? What happens? How do you manage those particular cases as they continue to grow over time?
So it's early onset scoliosis is one of those areas within orthopedics we haven't solved. Adolescent idiopathic scoliosis, we're going to come up with some probably better treatments over time, but by and large, a child who has an idiopathic scoliosis as an adolescent is going to do fine, and they're going to be okay. Early onset scoliosis is not the same. First of all, it's it's not a homogeneous population. It is a very heterogeneous population of children who have syndromes, congenital scoliosis, neuromuscular scoliosis, as well as idiopathic. And these children, if the scoliosis progresses terribly, will end up crushing their lungs over time. And that's been shown again and again. And our treatments have all been based upon, well, we need to make the curve straighter. And with the hope that by making the curve straighter, we're going to solve the child's issues. And we haven't. We can make the curve straighter, the lungs still don't function. We can try to get the spine to grow, but we're not sure that just making the spine grow actually makes all the changes that we need either, because you need to have an effective, the lungs and the chest and the diaphragm are all essentially a bellows. And you need to be able to have that bellows function, whether it's with the ribs and the diaphragm or with the function of the lungs, the structure of the lungs themselves, all of those things that matter a lot. To have normal lung function and rib function, you need the ribs to move, you need the diaphragm to move, and so that you can do the exchange of air. And then it has to grow in all the various dimensions for it to happen. So, we started out doing scoliosis casting and had some good success in terms of managing the chest wall deformity, and particularly in the children who had an idiopathic scoliosis. But once you have to go to the surgical range, we struggle. And if you look at sort of the history of what's happened, there's every decade or so, there's a new device that someone comes up with. And this new device is the best thing ever, and it's going to solve early onset scoliosis. It started out with early on with the Harrington rod. And the Harrington rods were developed. And then John Moe and some people in Europe began putting these in without doing a fusion and trying to get the children to grow and going back and stretching them. And I can tell you, when I went back to look at the things for crankshaft phenomena at Scottish Rite, I came across a number of these children, and they just had so many complications: rod breakages, skin problems, rods sticking outside of the skin. And then the next thing that came along was Eduardo Lucchi developed his instrumentation of the spine with segmental instrumentation and doing wires, which would attach the spine to different things and different parts of it. And Lucchi thought the same thing. Well, if I can just get the spine to grow in some of these kids, it would be nice. So he put in his rods without doing the fusion, and then getting them to grow. And once in a while, it would really grow nicely. But the first patient that I saw with massive crankshaft of the spine was a child that my dad had actually treated and had done sublaminar wiring. And we went back in to explore it because his chest had just twisted around this thing and found a solid fusion despite no fusion being done. And that's been a perpetual problem with all of the instrumentation that's been done. I was fortunate enough as a resident to work with Bob Campbell. He was in San Antonio when I was a resident. He developed the VEPTR device. That was the next thing that was solving early onset scoliosis. And it made some changes. It's really helped some children's lives, but the chest walls would begin to fuse. And so all of the things that you want with the ribs didn't happen. And then came dual growing rods. Well, it didn't work with the doubles. Let's go with the dual growing rods. And it's a nice change. It's more stable than the Harrington, maybe less fusion than you had with the Lucchi trolley. But the spine began to fuse spontaneously with those. And lots of operations on children. The children were always stressed out. And then finally, next came the magic rods. And the Sheila came on about the same time. And I wish I could say that all of those were complication free. They're not. We can get some spine length with some of these. Sometimes we have some really wonderful results, but oftentimes it's a real struggle to get the child to a better spot. We're not always even sure that we've gotten the child to a better spot. We found some tools along the way which have been really helpful. Halographic Traction has been probably one of the best tools that we have on these children with large curves to gradually get them stretched out and then to do something with them. But we're trying to fight a disorder that we don't really understand the biology. And I think that's one of our biggest problems. Until we can understand the biology better on early onset scoliosis and direct it much more directly, what's going on? Is it a problem with the bones? Is it a problem with the discs, with the muscles, with the ligaments? What's going on that we need to solve to be able to treat these things and do it well? I think we're going to continue to struggle. Personally, right now, if I'm faced with a child who needs to have surgery for this, if their curves are large, I will do halographic traction. If I can, I will try to do the magnetically controlled rods for the specific curve. Some of the curves are more amenable to the Schilla type of instrumentation where you try to get the spine to grow. Particularly, I think some of the children who are more fragile that you're trying to put a rod in, you really don't want to go back and reoperate on them again. But even those, I've had to go back and reoperate again. So it's an unsolved area of orthopedics, one that I find fascinating. I love the patients, parents are great, but if we really want to invest in research in scoliosis, we need to solve early onset scoliosis.
Excellent. I totally agree. It sounds super frustrating from everyone's point of view.
And we can do the magic rods or the Schilla, and they look wonderful initially. And then over time.
Is it primarily because of also it's just so much growth left in the child that you just don't know what's going to happen?
The big problems are there's a lot of growth that you're trying to make up for. Anytime you do something to the spine in a child, it tends to fuse and get stiff. If you put something on the ribs get stiffer. And we don't truly understand even how to measure our outcomes. It's not based upon the Cobb angle. It's really based upon the child's function in the end. We need to get better measures of function in the end.
Eventually, as they hit adolescence and adulthood, what tends to be the outcomes over those periods of time?
So it varies. So I've got I've got a number of children with casting that I've been able to see for many years. A number of them that we've done early casting, the curve's gone away and it stayed away. There's another group of those children in whom the curve begins to come back as an adolescent. Well, if it comes back as an adolescent, we've got pretty good treatments for those. So whether you're doing the vertebral body tethering or if you're going to go and do a standard fusion, those outcomes tend to, at least in the end, be okay. But there's a small subgroup of kids that either have neuromuscular disorders or they develop really severe curves over time that they kind of do okay. Some of them still end up in pulmonary failure as late adolescents and just with a lot of struggles. Their bone is soft, it fuses spontaneously, the tissues get stiff, they don't grow normally, they undergo a lot of surgeries, which clearly any child who's having a whole lot of surgeries, you can get this post-traumatic stress disorder type of thing that goes along with it. And just all kinds of challenges.
As I was mentioning Dr. Sanders before, on the internet and a lot of different groups, you always hear about the disasters of surgery with respect to scoliosis, and you don't hear about great cases. And I was wondering if you could speak to the study that you just published in terms of the long-term outcomes.
Yeah, so so many people who are looking at scoliosis realize that the first effective instrumentation for scoliosis was developed by Paul Harrington. Back in the late 1950s, he developed it. He published on it in the early 1960s. And there were a few centers that adopted it early. Clearly, down in Houston, they were doing it for quite a while. Actually, my dad was one of Paul Harrington's residents. So he tells me that I got to play basketball with Paul Harrington when I was a little kid. And one of the early adopters was Lou Goldstein at the University of Rochester. and he had done a lot of scoliosis before the Harrington instrumentation, where he would do the fusions with the body cast. And then he was an early adopter of the Harrington instrumentation. And because of that, he ended up attracting patients from all over. And he was a very skilled surgeon. He wrote up his technique. It's been published, and so you can go back and you can find what he did. There were some early attempts to begin following up all of the patients who had scoliosis that were done by Howard Ginsberg, and many people have heard of Professor Suk in Korea. He was one of Goldstein's residents at the University of Rochester. And so there were some attempts to begin following those patients up over time. They didn't get published. And so I started the University of Rochester in 2008. And they had saved several of the folks. Paul Rubry had made sure that they had saved the records and the x-rays on a bunch of these patients. So I began putting them all together, digitizing all of the films, and we started working very hard on trying to track down the patients. And we were able to track down, we found there were about 300 and some odd patients that he treated with Harrington instrumentation with adolescent idiopathic scoliosis. And we were able to track down somewhat close to half of them, not quite half, but about half of them. There were a certain percentage of them who had passed away. And then there were several who decided that they didn't want to participate in the study. But we ended up having 79, 80 patients with 45 roughly years of follow-up that we were able to get outcomes on. There's a smaller group that we've been able to get x-rays on, and some pulmonary function testing that we still have to do some of the research on. But so what we ended up publishing was this, how were their functional outcomes over time? And we ended up categorizing the patients based upon whether they had a fusion down to L3 or somewhere above that, or to L4 and below. And that was based on a systematic review that we had done a few years previously, looking in the literature, because everybody has said, don't fuse to L4 because results are terrible, stop at L3 all the time. And what we found is that if you were fused down to L3, that your chances of needing revision surgery were not very high. They were about 12%. So it wasn't a large group that needed to have revision surgery. It increased if you went down to L4. It was, I'd have to go back and look at the paper. I think it was around 28%. So, 2 to 3 times what it was, but it wasn't 100%, and it wasn't even 50%. It was, so less than a third of the patients ended up needing to have some form of revision surgery, even if they were fused down to L4. And with Harrington instrumentation, the big concern has been, do you create a flat back? And maybe it universally creates a flat back, and therefore patients can have problems. Well, clearly that wasn't the case, because they didn't need revision surgery. And when you look at the outcomes of the patients, of all of them, they were about the same as the adult population of the same age in the US. So what we found is that this old-fashioned Harrington instrumentation and fusion actually created very good long-term results for this cohort of patients. Now, there were patients who we couldn't follow up, we didn't know what had happened, there were a few who refused to participate. So maybe we'd find, if we were able to ever gather those patients, maybe they didn't do that well, but it certainly seems that they did. Our next step on this is actually the group in Iowa, where they did the long-term follow-up that Stu Weinstein had done. So we actually captured the same outcome instrument that they did. And I've been speaking with Stu and with Laurie Dolan for quite a while about this. And our hope is that we can sort of combine and begin seeing, is there a difference in the surgical and the non-surgical groups of those patients over time. So that's the study. And I think it should at least give patients some reassurance that the old-fashioned instrumentation and fusion isn't a bad option in the end.
Excellent. I think that's it's great to hear the data. It's great to look at the research, and it's great to look at the long-term outcomes. That's because that's the only way you're going to know, or have an inkling of where the truth lies, right? So it's pretty fascinating. And yes, I think I'm looking forward very much to see what you, Dr. Weinstein, can pull out of your hat.
Oh, hopefully we can pull something good out of our hat. Remains to be seen.
Is there any timeline on when you'll be releasing it from a published paper for that? Or?
No, we still have the work to do.
Okay. Very good. I think that's probably a good place to stop.
Okay.
Very much appreciate your time, Dr. Sanders, and thank you so much for the insight on the Sanders classification system, for touching on the difficulty of treating EOS and the long-term outcomes of fusion, maybe aren't as bad as we thought they were. Thank you so much for your time.
At least as an adolescent.
At least as an adolescent.
At least as an adolescent.
Thanks
Dr.
for
Lee, thank you very much. I appreciate you doing this.
Oh, appreciate your time. Thank you so much.
Have a good one.